Good afternoon and hello everyone. Welcome to the FTCA Office Hour for Health Center Clinical Leaders. Today's date is December the 15th. This event is sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. You've joined this online event by physically dialing in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 60 minutes, including introductions, a very brief presentation, and of course, a live Q&A. Again, the duration of today's event is 60 minutes, including introductions, presentation, and Q&A. If you have questions throughout today's event, please use the chat box. It's located in the lower right-hand side of your screen. Simply pop that box open, type your questions in. Make sure you select the to everyone in the drop-down panel. Very, very important. Again, in the chat box, go ahead and type your question. Select the to everyone in the drop-down section and place your question into this box at any time. Friendly reminders that today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. Chat box is open and will be open for the duration of this event. And we will answer as many questions as appropriately we can during today's session. If for some odd reason we can't answer your question in the time allotted or we need additional resources, we'll make an attempt after the event is completed. At this moment, I'm going to turn things over to Molly, who's going to be moderating today's session and kicking things off. Molly, the floor is yours.
Thanks, Liz, and welcome everyone. We're happy to be here today. I am lucky to be here with my fellow expert panelists, and I'd love for them to have a chance to introduce themselves. And so just based on my screen, it looks like Keith is closest to me, so I'll ask him to go first.
Hi, I'm Keith Horwood. I'm a family doc. I work for Community Health Centers Incorporated in Salt Lake City. I have been with them since 1989. Was the medical director for about 16 years and am now serving as associate medical director and risk manager. I'm looking forward to hearing what I learned from all of you.
Thanks, Keith. And next we have Dr. Johnson, Yvonne Johnson.
Hi, my name is Dr. Yvonne Johnson. I am a pediatrician by training, but now I'm the Chief Medical Officer at Medical Associates Plus, which is in Augusta, Georgia. I've been connected with health centers since '89, with this health center just for the last 2 years. And like Keith said, we learn something every time and we like to share what we know. So looking forward.
Thank you. And Marty, last but not least.
Hi, I'm Marty Bree. I'm with Feldesman Tucker Leifer Fidell, providing a lot of FTCA services to health centers. I've been working with health centers since 1976. I spent 28 years as a commissioned officer in the public health service, working almost exclusively during those years with health centers. And I'm happy to be here.
Thanks, Marty. So today we're going to take some time to just review some of the issues that have come up for health centers, at least the ones that we've heard about. I'm sure that there are plenty of other issues that you deal with on a day-to-day basis that haven't necessarily bubbled up, but these are what we hear about in our practice and what we've spent time talking to both Dr. Horwood and Dr. Johnson about in terms of issues that have come up during the pandemic. So we will review these briefly and then we'll get into the pre-submitted questions. And so to begin with, Marty, could you talk us through the telehealth issues that have come up over the last 18 months, 19 months, 20 months, in terms of how they relate to FTCA? Certainly there are a lot of other issues around telehealth. There have been a lot of flexibilities around billing. There's an ever-changing landscape, but with respect to the FTCA program, telehealth, could you talk us through that?
Sure. Since the advent of the pandemic, we've all been involved in the utilization of telehealth as a means to deliver services much more dramatically than we had in the past. And that's not likely that will decrease regardless of the status of this pandemic. Telehealth appears to be here to stay as a means of providing services. So what were some of the issues we ran across at first when we started to implement services via telehealth? Well, one issue that comes up clearly is the issue of the health center patient. Is this person that we're providing a service via telehealth to, are they a quote health center patient as defined in the FTCA manual? Another issue we run up against is the location of the patient and the provider when it comes to the question of licensing and scope of employment. Let me briefly go through that question. And during the pandemic, health centers have been permitting their providers to provide services to their patients via telehealth while the provider may not be at the health center. In many cases, the provider may be at their home providing the service. This could create a question around your scope of employment. You need to look at your position descriptions and employment agreements with your providers to see if they have language in them that requires them to provide services at a particular location. If that's the case, you may have some issues around scope of employment if there's an FTCA claim and the provider is not at the health center. So if we're letting our providers provide the service at their homes, we want to make sure that that's not in conflict with anything we say in the employment agreement, the scope of the position description, or any internal health center policy. We've got to have consistency there with this issue of where the provider is. Second issue around this provider-patient location, and we've talked about it in the past, is one of licensing. Prior to the pandemic, many states, in fact, the majority of states, had required you to have a license in the jurisdiction that the patient was located in. So if you're in a health center and some of your patients now are in a different state, maybe you are located close to the state line, and you're providing the service to the patient in that other state, you had to worry about that. I need a license in that other state to do that. During this pandemic, many states have eased that requirement, creating temporary easing of this licensing requirement. Many states have rescinded that, feeling that the emergency is no longer exists. So you need to be cognizant about the states where you may be providing services and what their current rules are regarding licenses. Another issue that came up was what kind of consent do we need from the patient to provide the service via telehealth. And our recommendation, of course, is that you get the consent from the patient for the telehealth visit prior to actually conducting that visit. And many times you'll have someone from the health center call ahead of the scheduled visit and gather up the information that you typically need to gather when they come into the office. And at that time, you get the consent to have the telehealth visit. But it's something we need to remember. Health centers, now that we're so involved in using telehealth services, you should have an internal policy around telehealth, how you're going to conduct it, what platforms that your providers are using that are acceptable to you, when and where it can be used. So a comprehensive telehealth policy is really a must now for health centers in order to assure that you're going to be compliant with all of the various rules that different agencies have around the use of telehealth services. Point out that there's a PAL on telehealth from HRSA that kind of helps you to how you would fill out Form 5A if you're providing some of those services via telehealth. And that's a quick review of the telehealth issue.
Thanks, Marty. Keith or Yvonne, do you have any comments from your experience in using telehealth during the pandemic and risk management or FTCA related issues around that?
Only thing I would say is that one issue that's come up is knowing where your patient is, because they kept changing the rules during COVID. That's one thing. Like Marty just said, you really got to pay attention to the laws and know what's happening, and it's very dynamic. It's not like what you saw at the beginning of COVID is necessarily going to be the same 6 months later, right? But
Exactly.
so let's say you might be able to, if you're taking care of your patient, there's issue of you're practicing in your state where you're licensed, or states where you're licensed, and then the patient goes home to shelter in place with their family or something. They're in a totally different state. So are you practicing across state lines? Do they even tell you that they're somewhere else? I mean, they do not necessarily tell you. It's not like you have a tracker on them, right? And so some of those rules, I think, changed during COVID. Again, Marty can help with that, but I know that there was some laxity, and you could practice across state lines, but like I said, it depends on your state, and it depends on what state you're practicing into.
Exactly. Exactly.
Yeah,
Keith,
the other
did you have-
comment I would make is as we're sort of coming out of this, patients have developed an expectation now, oh, I can get all my care on telehealth. I don't have to go in at all. And gee, why are you saying I have to come to the clinic to get my A1C checked? You haven't checked it in a year. Well, I haven't checked it in a year because there was a reason that we were really concerned about you being here, but I can't continue to fly blind. I need to see you. I need to lay hands on you. And I think important to sort of make sure that your clinicians feel supported in being able to say, this service I can provide for you in this way by telehealth, but this other service, no, I can't really do good medicine for you. And I realize that this is inconvenient, but I can't be ethical. I can't give you good care without actually seeing you, without actually measuring your blood pressure and listening to your lungs, etc. Making sure your providers know that they have the support from their health center to be able to do that, to set some limits if that's necessary.
Which
That's
I'm
great.
going to piggyback on that. I hope I'm not muted. Yeah, I'm on mute. Okay, I'm going to piggyback on that again. That's a good point, Keith. But another thing that I think is picked up during this time is us being able to virtually assess stuff like people's blood pressures, their blood sugar. Having everybody doesn't have it, but I think there's some FCC grants. There's some different ways to have access to give people Bluetooth-enabled equipment that can actually feed into their electronic health record, and you have, again, a process for knowing when you need to be following up on people. You still, like Keith said, want people to come in. You don't want them to go away for years and you don't see them, but at least you can follow them for some refills around some things, around their blood sugars, around their blood pressure, weight and BMI, BMI, all those kinds of things. There are some alternate ways to deal with that if you need to for a season.
Those are great points. Thank you. Okay, some of the other issues to review. Immunizations, and I'm just gonna hope that we can just talk through these so we make sure we leave enough time for questions. Immunizations, testing and other offsite services, and volunteers. And actually, we had a really interesting back and forth yesterday about the volunteers in FTCA. So Marty, can you walk us through these other issues that have come up during COVID?
Definitely. First issue around immunizations was, well, can we go and offsite and immunize people at other locations? And what about those who are not health center patients? Well, HRSA really addressed that question back in 1995, again in 2013, and then again in last year. And the answer, of course, is yes. You have FTCA coverage for the immunization of non-health center patients. There's an exception in the regulations specifically for immunization campaign. Again, location, yeah, you can go off-site and do that, definitely within your service area, and have protection. You probably have protection too within the adjacent political jurisdictions that surround you. If you decide to go too far afield and operate some sort of a vaccine clinic, it's possible that there might be problems. But that's a kind of fact-based question that you'd have to look at the exact situation. But if you're in your service area or in adjacent political subdivisions during this pandemic, providing vaccinations, you can be confident that you'll have your FTCA protection. In addition to that, there are other liability protections available via different statutes that have been passed. The PrEP Act is one that would provide you with some liability protection in the event you're giving a vaccine and you get sued. So there's a lot of layers of protection. I'm really not that worried about your liability protections in the administering of vaccines. But Molly, you're going to talk later on. I think we have a question later on about mandates and immunization. So let's put that question back to when we look at those others. Testing and other off-site services. We had questions around non-health center patients. When you're off-site, cooperating with another entity of some sort, maybe a health department, in the provision of services. What about the non-health center patient? That one is not as clean or clear as the vaccine or immunization situation. You can, if you're providing the service on behalf of the health center and following the guidance that HRSA has provided through their FAQs on the website, there can be FTCA coverage of those kinds of service provision outside of your sites. But again, I'm going to have to say that's really a fact-specific kind of a question. And you want to really get a good answer on that. Volunteers. Generally, volunteers are not protected by the health center program. There is a separate program for volunteers in health centers where you have to apply for the individual volunteer and you can get them FTCA protection, very similar to your protection. The interesting thing to note, and we discovered it, and we probably read it many times over the past years, but it was kind of hiding in plain sight. At the very end of the statute, there's a expiration date or a sunset date for that program, which was October 1st of 2022. So as of today, the FTCA program for volunteers at health centers expires on the last day of September 2022. And whether or not that's going to get extended and whether NAC is, I don't know, NAC may very well be on top of this already. But that's an issue that we have to keep in mind.
There was a question. Oh, sorry. Go ahead.
I just want to make sure, this may seem obvious, but sometimes it's not. Especially when you, with whatever patients you're taking care of, especially when we're doing immunization drives, et cetera, or taking care of non-health center patients, make sure you identify who you're treating, make sure they're of age to give consent. Make sure that they're giving consent for a child. There's somebody that can give consent for that child, because families are kind of torn on this COVID issue. So you might have a father, have somebody bring the person in to get the vaccine and the other family member doesn't. Well, that's fine if you have it signed properly. But if you just don't follow the same rules you would follow if you were in the office for giving this information, et cetera, it can be a problem. So you've got to make sure you do all of that stuff too.
Great point. There was a question in the chat, Marty, if you could, that I thought would be helpful for everyone to clarify. That says offsite services must be listed on Form 5, correct? Can you just address where those sorts of things live?
Yes, the service that you're providing would have to be a service that you find on Form 5A. So that service has got to be a service that's in the scope of project. The location where you're providing it, likely you should have on Form 5C.
Exactly. Thank you. Keith, did you have anything you wanted to add to these issues?
I just had a clarifying question about that. So if you're participating in a county immunization drive or testing at a site you haven't been to before, does that mean you're submitting a change of scope, or is that covered by the while participating in a community-wide drive, you're covered?
Well, let's talk about how to ideally guarantee your protection. And that would mean I would like to see the activity on Form 5C. Now, to add an activity on Form 5C, it's not as rigorous as a change of scope to Form 5A and 5B. You really should have no trouble adding an immunization campaign to Form 5C. I understand that may take time. You've got to deal with the EHB, and you can't just enter it today, and it's now and it's right there. So I would always, in the interim, inform my project officer that I have entered this into EHB, that we are doing this consistent with the HRSA's program guidance on it. And don't forget, we also have a document, a particularized determination issued by the Bureau Director that states that you will have FTCA protection for the provision of COVID-19 services to non-health center patients. Okay, and it does, and that determination speaks to the fact that it doesn't have to be they're not at a health center site. So we have that coverage via that particularized determination. You probably don't need a listing in 5C, but and I think Molly and I always recommend that let's cover all bases when we're doing things that are not in the health center.
Let me add something to that. This is something we experienced ourselves. We added a COVID vaccine and testing van. And now you have to make sure that you add that. Apparently when you would add another site, then it would come into your coverage, FTCA coverage. Like it was kind of an assumed thing that, you've added this site. Feds are well aware that you're adding the site, but you have to specifically make a point of putting the information into the EHB to have this site added for this testing and approved differently than it used to be for adding another site.
Right. If you want to have a mobile van, and health centers are doing this now, if you can add that mobile van to Form 5B, the listing of your sites, then you eliminate a lot of problems, because anybody who gets service in that van is now by definition a health center patient. We don't have the question of the non-health center patient anymore. So ideally, yes, you get that mobile van on Form 5B, which is more rigorous than just adding it as a portable clinical care on Form 5C.
Exactly.
Great.
Okay. Other issues for FTCA during COVID for clinical leaders, talking through the other liability protections. I think, Marty, you mentioned these in one of the earlier slides, and then also talking about non-health center patients. We've sort of covered both of these, but anything else you want to say on the liability protections or the non-health center patients?
The PrEP Act is a complicated piece of legislation, but does provide protections for specific activities for clinicians and even non-clinicians. The CARES Act provides some protection for volunteers. State Good Samaritan laws vary dramatically from one state to another, but may provide some form of protection during the pandemic for situations that are potentially not covered under the FTCA program. And you should be cognizant about your particular state and what laws they have passed. Many states have passed laws regarding some immunities during this period of time. And many states have passed multiple laws and gone back and forth and changed those laws. So you have to really be on top of what's going on in your state. Okay? And with non-health center patients, provision of COVID-19 services to non-health center patients is generally covered because of the particularized determination published, and I believe it was in March of 2021. The only thing about that is somewhat confusing is there's nothing in that document about its expiration. So one would think it would expire at the end of the declared emergency, but it doesn't say that. So we're waiting with the bated breath from for HRSA to give us some guidance on when they believe that ends, when they will rescind it, if ever.
Thanks, Marty. And then just a reminder or a review on credentialing and privileging, some issues and areas to be aware of. Marty, can you talk through volunteers as well as the streamlined process, and then Yvonne and Keith can give us their thoughts if they had any particular experiences or any advice around credentialing and privileging.
Well, yeah, the point around volunteers is that they must be credentialed and privileged. Simply the fact that there are volunteers doesn't eliminate your obligation to assure that they are capable of providing the services that that you intend for them to provide. During this emergency, and we may want to add, or you may have wanted to add staff and do it in a more timely fashion than you could in the past. HRSA does have a policy on how you can temporarily privilege clinical providers during declared emergencies. You should look at that, PAL, and make certain that what you're doing is consistent with their expectations, and it does save some time.
Do you want to comment on, sometimes we've been getting questions about people that have temporary privileging procedures in their credentialing and privileging procedure that are not tied to emergency situations, and what we've seen HRSA reviewers do with that?
Well, yeah, we've had a problem with HRSA reviewers arguing that the only circumstance where you can provide temporary privileges is during a declared emergency, and that under no other circumstances can you have a temporary privileging. That's not consistent with the compliance manual, which doesn't use the term temporary privileging. The manual makes no recognition whatsoever of it, whether you can or cannot do it. And we've always felt that anything that the manual ignores is left up to the health center's discretion. Apparently some OSV and FTCA reviewers believe that HRSA's PAL creates the only exception to a prohibition on temporary privileging, which doesn't exist in the compliance manual. So we really haven't got a resolution on that question. Yeah. And if you're getting reviewed, an OSV or an FTCA review, and the reviewer is citing you for having for granting temporary privileges outside of an emergency, I would just very nicely ask them to show you where that prohibition exists in the compliance manual. It might not help, but it might enlighten the reviewer, perhaps.
Thank you. Yvonne and Keith, do you have anything to add on credentialing?
I thought one of the issues, like Marty's saying, is that if you're actually, we've had a big turnover in providers, especially like the support staff, as people have gotten paid to stay at home, etc. So I think that another issue is if you have to have people and you're in a desperate search for folks, I mean, you're still going to always check to make sure there's somebody. I'm sorry, I didn't put myself back on. You're still going to make sure that you're hiring people that have the skills, etc., but you're just shortening that. You're getting them on board a little bit quicker and finishing out the rest of your process like if you're going to the board, et cetera, after you already have had them for that 90 days. You know, it gives you that flexibility, but it's also when you have a shortage of staff, like when we're having shortages, because maybe we have older docs, they might not want to work because they're at more risk from being exposed to COVID, right?
Mhm.
So in those kind of situations, that was another situation where you might end up doing this temporary privileging.
And don't forget, for everyone out there, that the compliance manual, speaking of things that are omitted, the compliance manual does not require you to get board approval for privileging. It says in the related considerations section that the health center has the flexibility to decide who is going to grant privileges. And so if your board process is slowing down your privileging, you can review that as a possible fix.
It's true.
But whatever your rules are, follow them. If
Exactly.
you say it must be the board and it must be this often, don't skip the board and don't do it less often.
Exactly. Okay. So questions that we have received ahead of this meeting, we'll get into now on slide 13. Is there anything related to employer vaccine mandates or OSHA ETS that is relevant to health centers?
Yes.
Yes.
And Molly, I think you could provide that answer.
Sure. So I think that's a broad question for me. Is there anything that is relevant or related? Yes. First of all, health centers are generally, well, let me back up. So there are currently 3 federal vaccine mandates, one for federal contractors, one the OSHA ETS, and then one under the CMS omnibus for certified Medicare and Medicaid facilities. Health centers fall under the CMS rule, which means that they are not covered by the OSHA rule. Health centers that participate in Medicare and have a Medicare and likely Medicaid, but that's a whole other topic. The CMS mandate is the mandate that would apply to health centers. All 3 of those, and then if you have a federal contract, that mandate could also potentially apply to you. It is likely, if you are a health center, that the OSHA mandate does not apply to you. If you are not a health center and you have 100 or more employees, the OSHA mandate would apply to you. But not to bury the lead on that, all 3 of the mandates are currently in litigation, and the federal government is enjoined from enforcing them or moving forward on them right now. So that means that none of the mandates are in play right now. They're in litigation. We'll see what happens. And so to the extent that the CMS rule is determined by the courts to be lawful, that CMS mandate would apply. And then employer vaccine mandates, health centers could have their own individual employer vaccine mandate, and we've worked with a lot of health centers that have mandated the vaccine themselves. You need to be careful about your state law and make sure that any mandate that you have is in alignment with your state law. And states have a wide variety of issues, or I should say, rules around having mandates or not. So you need to be crystal clear on that and work with legal counsel to ensure that your mandate is legal in your state. But that's how I would say they're related to health centers, or relevant to health centers rather. Okay. The second question is there a final date that all health center employees need to have completed the COVID vaccine for the health center to be in compliance with the president's COVID-19 ruling? What is that date and what happens if not compliant? So no, there's not a date right now. Originally under the CMS rule and actually under the OSHA rule, the dates were December 6th for the first dose of a 2-dose primary vaccination series, or if you were getting the J&J vaccine, it would be December 6th, and then January 4th for the second dose. Because those rules are enjoined, that means that there is no final date at this time. We are waiting to see what happens. And we will continue to pay attention, of course, and keep health centers up to date. If the rule were to be held lawful and go back into place, and so say the CMS mandate is back, what happens if you're not compliant with it? What would happen, what CMS has said would happen is that they would have, this would be something that they survey on as part of their state surveys, and they would evaluate it, and you could have basically a progressive disciplinary action, for lack of a better term, that could ultimately mean that you can't participate in Medicare and Medicaid, but would not be the first thing that happened. There would be a process in place. The other thing that's important to know about health centers and how they are unique is that all of the other Medicare and Medicaid certified facilities have surveys as part of their certification process. So a state surveyor will come on site and evaluate the organization based on the requirements and the conditions of participation or conditions of certification, et cetera. Because health centers are this unique animal, they don't have that survey process. So at this time, it's unclear how CMS would evaluate health center compliance, but by CMS's own admission in the rules, it's clear that CMS is anticipating that health centers have to be to participate and have to be compliant with the rule if the rule is held to be legal. How are other health centers handling vaccine exemptions? I've worked with a lot of health centers that are enforcing their own mandate and accepting exemptions. Again, you need to be clear in terms of the state you live in terms of what the state is allowing for exemptions, particularly since there's not a federal mandate at this time. So in terms of how other health centers are handling exemptions, they are using a process to accept medical and religious exemption requests. They are gathering together as a committee oftentimes, or a group of people to evaluate whether or not the exemption requests pass muster, and evaluate that, and then evaluate what reasonable accommodations they're going to offer. We did a webinar on the vaccine exemptions. We've done several from Feldesman Tucker. We have some of our own, but we also did one with NAC that I believe is available for free. So you can take a look on the Feldesman Tucker website, and that might give you some more help on the vaccine exemptions, because it's certainly complicated. Okay, who is covered by FTCA to give injections, vaccinations, and medications? Specifically covering registered MAs that became registered through the organization but not state licensed professionals. Are they covered to perform under the supervision of a licensed practitioner? I'm going to give that to Marty.
Thanks for that.
You're welcome.
Yeah, the question gets raised in a lot of ways. We've had a number of questions about dentists and dental staff giving injections or vaccines, rather, and as well as questions around medical assistants giving vaccines. The first question you'd have to ask is, what is your state law around the giving of vaccinations, and who can and cannot give vaccines? And strangely enough, and I forget what state it was, but I saw that the dentists were not permitted to give vaccines. But you have to check with your state law first off. If there's no state prohibition against giving the vaccine, then it's incumbent upon the health center to make certain that the individual, the clinical staff member, be it the dentist or be it the MA, is capable of doing that. and may require some training and mentoring or proctoring for a little bit before you allow an MA, for example, to give a vaccine. Would that person be covered under the FTCA? If they're employees, they are going to be protected as long as they are acting within their scope of employment. So if you're going to add a new duty for an MA, that would be to give vaccines, then you'd want to make sure that the employment documents, a position description perhaps, would not preclude the provision of vaccines. So you may want to, you have to look at your employment agreements or your position descriptions, making sure there's consistency again with what you're having that person do and what's in writing. Now I said that was for employees. If you're a contractor, and typically you don't see contract MAs, contractors have to be licensed or certified healthcare practitioners. So if you by some chance had an MA who wasn't licensed or certified, they couldn't be covered as a contractor. Contractors also have to be full-time unless you're providing family practice, pediatrics, general internal medicine, or OBGYN services. I think that kind of summarizes the situation around vaccinations.
Could I piggyback on that, please?
Please.
Do.
Okay, so the issue about training is a good source is CDC, their website. They have training for them, and they specifically say what kind of folks need to be trained. So even if you're an experienced vaccinator, you need to be trained around COVID vaccines because you want to make sure people are prepared for any of these side effects, etc. Vaccinators who haven't administered vaccines in the past 12 months or longer, medical support staff not licensed to administer vaccines, but can assist with vaccine preparation and cold chain management. I'm sure people don't think about that. You're just thinking about who actually gives a vaccine, but you need anybody along that chain to be trained, and administrative support staff. They can help with the management, the data reporting, distribution of vaccines. There's another thing I was going to say. Oh, in Georgia, initially, MAs were not allowed to give the vaccine. At first, it was LPNs only. So again, and then there were so many complaints because we just didn't have enough LPNs or RNs to do it. So again, this stuff is changing in your state. You really literally have to check at the point when you're implementing stuff and make sure that you're doing what is legal in your state.
Great point. Great point.
In Utah, I have a great deal of freedom. Essentially, anybody who wants to give a vaccine,
Oh, Keith, we lost your audio. We can't hear you.
Okay.
Oh, now we can.
Yeah, I'll reboot.
No, we can hear you now.
Oh, you can. Okay. So in my state, I have a great deal of freedom. People can do vaccines, whether they're licensed or certified in any way. If I say they're allowed to do it under my license, that means I have the burden of knowing that they can do it appropriately. And so I want to document that training. But an additional concern that you might have, depending on your state, is that there are some states that will have union rules between MAs, LPNs, RNs, other certified folks that you also want to sort of check on, or you may be stepping on toes that you don't want to step on.
Oh, that's a great point. Like looking at the collective bargaining agreement or otherwise to ensure that you're not. That's a great point. I've never thought of that. Okay. What protocols for COVID-19 screening, if any, exemption allowed unvaccinated staff? What protocols for, if any, exemption allowed unvaccinated staff? How are CMOs who are clinical getting peer-reviewed chart audits? How do we find those excelling in UDS measures and get assistance, guidance, or expertise? I'm going to hand these questions over to Keith and Yvonne.
So I can jump in on the CMO peer review. Hopefully they're getting peer review the exact same way everybody else in your organization is getting peer review. You define a set of questions that you want to measure on the chart. Someone audits it. It could be someone who just pushes buttons on the computer, because we can do that now with an EMR, or it could be teams who review them. In our organization, at least once a year, we try and do our chart review, not just with the clinician, but with their support team, because a great deal of the documentation that goes into showing the quality that we do is really in the hands of the MAs who are helping us record and prepping for visits and finishing for visits. But you should have a measurement tool that allows you to say, this is how you did. We measured it the same way that someone else did. And it doesn't necessarily need to be. If it's someone who's in a specialty that has no peer within your organization, let's say you have one psychiatrist who supervises much of your medical management, then you may need to contract with someone outside of your organization to do periodic review. But whether they're the CMO or not is not as much of a problem as just, do you do the audit in the same way? And the answer should be yes, and hopefully transparently, so that as you do those audits, you can identify within your own organization, and your clinicians can look and see, man, who's doing a really good job of this? I'm going to go talk with them and see what are they getting their team to do that makes this work? Or I'm really struggling with this, man, I better figure out who I can talk to. So same as everyone else, but with all the transparency that you can provide.
Thanks, Keith. Yvonne, do you have other helpful information to add? That was really helpful.
The thing is with the CM, I'm not clinical anymore, but when I was clinical, it just has to, I'm a pediatrician, I'd have a pediatrician do my reviews. And like Keith said, it does make you stay on your toes because you want them to do as you do and say, not just what you say.
Any guidance on excelling in UDS measures?
Can't we check? We can go to you can go to HRSA and see how people are doing on the UDS measures, right? That's generally available information. Is it not?
Yes, it's
I
public
think so. I think that
Yeah. I think I've gone and looked. So you
question
can
as though
contact people.
if you're getting great, if you're doing really well, how do you find people that are doing really well that can help your health center?
I would
Yeah,
either go to the PCA or I'd go to the HRSA site and look at UDS and see how people are doing in your state, because you can even do that just.
Oh, and then just reach out. That's a great point. That's a great idea. I
Right.
see.
Go to
You
either
can
one
use
of
either UDS tracker, which you can
Right. You're gone again, Keith.
place.
That's what it is. Yeah, it is
Yeah.
UDS tracker, and you can go in and see how everybody in your state's doing on a given thing, and then you can contact them. Or if you don't know how to do that, or if you just want to do short, you can contact the PCA and they can help direct you.
Right. And it's helpful to sort of look at the organization you're looking at. If they have a great score, but they're not similar to you, you're a big urban center that does a ton of Medicare, and you're looking at a small rural group that does mostly Ps. Well, those are not going to translate, but you can use the UDS tracker to look for groups that are similar to you, and then sort of track them down to see who might be helpful. As regard the other question here on unvaccinated staff, you need to have policy that's clear, that it's based on the science and not the individual. So if you decide this role must be patient facing and therefore needs to have vaccinated, if the job cannot be done without facing the patient, then the job cannot be done without facing the patient, as opposed to this role is mostly on the phone anyway, and if we provide an exemption for them, they can stay in their job, but you are not required to continue to have someone do a role that they can't do safely if they're unvaccinated, or that the patients can't be safe. But you want to make sure those are defined in your policies as these roles we define as, having a requirement because of what's done in the role, as opposed to something that someone might say, construe as, well, you let them do it because you like them and you didn't let me do it because you don't like me. Because those are not okay reasons to.
Great point.
This might be a point to also think about telehealth. And again, like Keith said, you've got to be, it's not just fair because it's hard to be fair, but you've got to have some kind of metrics to decide what counts as a religious exemption, what counts as a medical exemption. And like has been stated before, it has to be based on what's going on in your state, what we have nationally. You can find examples of what people are doing in other locations, etc.
Great. Okay. Next set of questions. Will dentists be allowed to administer other vaccines to bridge gaps in care? For example, flu, HPV. They have been granted an exemption to administer COVID, but what about other vaccines? Is there federal law that eclipses state law? No.
I do not know
Sorry.
any federal law that would eclipse state law.
Yeah, you got to look at your state law and see what's in their scope of practice. And there's not a federal law that allows, that really gets into that. Unfortunately, it's going to be based on what dentists are permitted to do in your state. During the pandemic, have there been increases in allegations of malpractice related to telehealth, such as allegations of misdiagnoses?
When I saw that question, I did make a query to the Office of the General Counsel around telehealth claims. And to this point, they have not seen any claims where telehealth is a factor in it at all. Not that they don't expect that to happen. But we need to remember that malpractice claims lag behind the actual incident. And with this dramatic increase in use of telehealth 18 months ago, if we're going to start seeing claims revolving around telehealth, we should start seeing them soon.
Yeah, I agree that it's probably a little too soon still to know, particularly on a failure to diagnose
Right.
Something, because that will come up later likely. Is there any reporting requirement as part of the FTCA application specifically pertaining to COVID-19?
Not in the past.
Right.
No. We are waiting the 2020 calendar year 2023 deeming application will be out 3 months, perhaps 2 months, 3 months, 4 months from now.
The next question is, what is specialty care? Children's dentists doing surgery at a hospital, volunteer physicians on site doing latent TB clinics?
So there is a tool on the HRSA site. It's called the service descriptors.
Yeah, I'm going to post that in the chat right now for everyone.
Yeah, service descriptors, and it's really good to go through, especially before you have a site visit, to make sure you're not calling when you're doing an eye check just to see if a kid can, a Snellen. When you're doing a Snellen, you don't say I have optometry. That's not the same thing. You've got to make sure you know who you're speaking of. But so a lot of things are special. We have a lot of specialty where I am. We have infectious disease, pulmonology, endocrinology, dermatology. Those are clearly specialty care. I think that when you do more detailed dental care, like periodontal services or endodontist or again, you got to look at this descriptors for additional services and see what falls under specialty care. Yeah, I think that,
yeah, I think that it's and to your point that if you are doing, once you look at gastroenterology, for example, and decide whether you're actually doing gastroenterology or what you're doing is part of internal medicine, family medicine, that's when you would have a decision point about making sure that you add that specialty to your Form 5A in order to assure that you have coverage for it.
But you need to do the basic stuff first, of course.
Absolutely. Okay. What is FTCA looking for in the quarterly risk assessment? What to put in the sample templates? Does anyone have any thoughts on the quarterly risk assessments?
I think I can give a pretty good answer to that, having been asked this question recently. They're really looking for an answer to the question, what are you doing in order to make sure that whatever either claim or judgment or miss or near miss happened in the past, what are you doing to try and make sure that that's less likely to happen in the future? We had an issue happen that that we felt was sort of part of the background of high risk of a particular thing that we're doing. And so when we first answered the question, we said, this happens sometimes. It's not possible to completely prevent. And that was not a very satisfying answer. Well, what we ended up doing is saying, well, these are the 8 things that we've been doing for the last 6 years, and we will keep doing them to make sure that we're reducing the risk as far as possible. And when they looked at the list, they said, oh, great, that's the stuff that we wanted you to do. We just wanted to hear that. So if you ask yourself the question, if there's a concern raised, whether it's a, near miss, claim, whatever, assess that and think about what could we be doing differently. I mean, it's not surprising that what they want to know is, what are you going to do to make sure that we don't, spend all of our budget paying out claims because, you're just continuing to make the same mistake. So what do you think you could do that would make this less likely to ever occur or to occur again in the future, depending on the context?
Let me piggyback on that too. I've been really blessed with having a great director of quality. She actually has moved to North Carolina, but she's still consulting with us, but she's taught us a lot on how to do this stuff. So I think one of the questions was a tool to use. There are 2 places to go. One is ECRI, doesn't stand for anything. That's the name of a company. So they clearly go through examples of how to do this stuff for patient safety. So one of the things they talk about in risk assessment, these are the kind of things you want to look at: documentation and record keeping, emergency preparedness. So for emergency preparedness, we did our tornado drills, we've done our earthquake drills, we've done our mock codes, those would be there. Infection prevention, we've done hand washing observation. That sounds like you should not have to do that, but let me tell you, you have to do it, and you might be sad when you see what that looks like. Medication, so you want to see, do people wash their hands before they see the patient, after they see the patient, all that kind of stuff, and just make people aware of that. Medication safety. The other tool that's really good is from the Institute for Healthcare Improvement. And this is something that we've done for, it's called Failure Modes and Effects Analysis Tool, FMEA tool. So you would say we want to reduce the risk priority number for the medication dispensing process by 50% in 6 months. So you see what kind of things are causing you to have problems with giving medication. So an example, a failure mode, the doctor indicates an incorrect strength or form of the medication. The cause was the doctor used an incorrect abbreviation or symbols indicating a solid strength versus a liquid strength. And we found out, some people put in the first couple of letters and something pops up. And if they don't pay attention, they really need to be going further down the list. The effects, the pharmacist would ultimately catch this error, but if the med was dispensed as written with a strength for liquid applied to a strength for solid, it could be harmful or dangerous to the patient. And so we put in an action to make sure there was more review and that you maybe had to put in more letters to get the initial meds. We've experimented with that kind of stuff. So another thing is an incorrect name on the script, or you can't read the name, or usually we're doing electronic, so that's not an issue. Or it's missing some important information like the NPI number or the physician number, or an incorrect abbreviations used. So anyway, this helped when they were asking for sample templates. Go to the Institute of Healthcare Improvement, look up Failure Modes and Effects Analysis, FMEA, and also go to ECRI. Those are just
Thank you. And
Yeah,
I think
those are great resources. And what I particularly like about the FMEA is that it's designed to ask that you don't have to wait for something bad to happen. You sit down and think about how could this get messed up? Can we anticipate? No, let's just not wait for a problem. Let's think about how could it cause trouble, and let's get in front of it.
absolutely. So I think that we're at time. I think the last question on this slide is, are there good sources of information to help us streamline activities? I think that I would just refer back to what Dr. Johnson said about ECRI and the Institute for, or IHI, which Katja just put on the link in the chat. There are 2 questions in the chat that we didn't get to, so we will follow up on those, and I will hand it back over to Liz to take us out. Thank you so much for being here, everyone. Thank you to our wonderful panelists, and everyone take care.
Thank you.
Happy end of the year. Merry Christmas.
Yeah.
Bye-bye.
Thanks,
Thank
Molly. We'll see you guys soon. Thank you.
you. Bye-bye.
Bye.